is Dr. Sarita Berry ma'am. Ma'am is Director, Lady Harding Medical College, and she is heading the retina services. Ma'am has a vast experience in this topic, and I hope you will gain some insight into it today. I am Dr. Neha Chawla Guliani. I am an assistant professor at the Department of Ophthalmology, Lady Harding Medical College. We have with us Dr. Rahul Bhatia. He is a consultant at Sharpsight Eye Center. We have Dr. Bharti Arya, who is a consultant, vitreoretina consultant at Medanta. And we have Dr. Aditya, who is a senior resident at the Department of Ophthalmology, Lady Harding Medical College. So today we'll be discussing from the overview etiopathogenesis to a case-based discussion of the evaluation of RVO, the clinical trials that have been done so far in relation to RVOs, then the management strategies, the anti-VEGF, steroids, and last but not the least, the role of lasers in RVO. So without any further ado, let us start with the overview. So retinal venous occlusion is the second most common retinal vascular disorder, second only to diabetic retinopathy, with a prevalence of 4 in 1,000 according to a meta-analysis done on 50,000 patients from 11 studies. They also found that branched retinal vein occlusion was much more common than central retinal vein occlusion. And in a study conducted in the rural population of central India, we had similar results with the incidence of RVO being 0.8% and BRVO being 7 times more common than CRVO. There is no gender predilection, affects males and females equally. But what is the point to be noted is that there is a risk factor of age. Most of the patients are above 65 years of age. How do we classify RVO? With the pioneering and extensive work of Dr. Sohan Singh Haire, he described 3 primary types of retinal vein occlusion, and each primary type had 2 subtypes, making it a total of 6 forms of RVO. First is the central retinal vein occlusion, where the entire venous system of the eye is affected, and the occlusion is at the level of lamina cribrosa or just posterior to it. Then we have the hemicentral retinal vein occlusion, where one hemisphere of the fundus is involved. It is due to the occlusion of one of the 2 trunks of the central retinal vein in the optic nerve. Then we have the branched retinal vein occlusion, where it is divided into major and macular depending on the site of the occlusion at the AV crossing. It could be major or macular. So in this figure, you can see the blue arrow point towards the site of insult of a major BRVO. The major vessel is affected, whereas the green arrow points towards a minor tributary draining the macula. So a macular BRVO. And CRVO and hemicentral retinal vein occlusion are further divided into an ischemic and non-ischemic variety. There is another entity where we have seen that RVOs might be associated with retinal artery occlusion as well. So there might be CRVO with CRAO, or CRVO with a branched retinal vein occlusion, or a cilio-retinal artery occlusion. So what exactly causes the retinal vein occlusion? Well, the exact pathogenesis still remains unclear, but what we do know is that there is a multifactorial etiology. The condition is due to a combination of 3 systemic changes known as the Virchow's triad, which includes hemodynamic changes, the venous stasis, degenerative changes of the vessel wall, and blood hypercoagulability, all these 3 acting to form a thrombus. So the site of CRVO, the insult is typically at or just posterior to the lamina cribrosa. Why so? Because in this site, the vein and the artery, they share a common adventitial sheath. For this reason, mechanical narrowing of the lumen of the thin wall vein due to the arteriosclerotic, rigid, hyperplastic, thick arterial wall will cause a venous occlusion. Whereas in BRVO, the site of insult or the site of occlusion is the AV crossing, where the artery crosses over the vein. So again, when the artery crosses over the vein and the artery is arteriosclerotic, it will cause a venous stasis, which is turbulent blood flow, producing injury to the endothelium and finally leading to the occlusion of the vein. Another thing to be understood is the pathogenesis of macular edema, because of most of the patients with BRVO, they come with diminished vision due to macular edema. So how does that happen? So when the vessel is occluded, when there is a blockage of the vessel, there is a back pressure leading on to hypoxia, which causes the release of vasopermeability factors or the VEGFs, which will cause the breakdown of the blood-retinal barrier, and this leads to fluid flux from vessels to tissues. So what are the risk factors leading on to a retinal vein occlusion? They can be systemic risk factors or ocular risk factors, glaucoma being the most common ocular risk factors. Amongst the systemic risk factors, first and the foremost is hypertension, which is seen in 2/3 of these patients. Diabetes mellitus is seen in around 15% of these patients, whereas hyperlipidemia can be seen in 1/3 of the patients with RVOs. And obviously there is the atherosclerotic associated diseases like ischemic heart disease and cigarette smoking. There are a set of risk factors which are more prone to cause an RVO in the younger age group, where arteriosclerosis might not be the main cause of causing the venous occlusion. So these are the occlusive periphlebitis due to systemic vasculitis like systemic lupus erythematosus, sarcoidosis, syphilis, or any hyperviscosity due to hematological neoplasia like polycythemia vera, multiple myeloma, leukemia, or hypercoagulable states like antiphospholipid syndrome, protein S deficiency, or the intake of drugs like oral contraceptives. As I had already told you, CRVO can be subdivided into an ischemic and a non-ischemic variant. Why is this important? Because the prognosis and management of these two entities is vastly different. So how do we differentiate between these two? We have certain morphological tests as well as functional tests. So first in the functional test is the visual acuity. It is seen that cases with ischemic CRVO at presentation they have poor vision, a vision of 20 by 100 or less, whereas non-ischemic CRVO has better visual acuity at presentation. RAPD or relative afferent pupillary defect is present in ischemic variant. So are dense central scotomas and peripheral visual field constriction on perimetry. And on ERG, the B wave amplitude is less than equal to 60% of the normal in cases of ischemic variant. Now morphologically on ophthalmoscopy, as you can see in these two pictures, the one on the left is the ischemic variant and the one on the right is the non-ischemic variant. So between the two, you can see more marked venous dilatation and more extensive hemorrhages and cotton wool spots in the ischemic variety. And on fundus fluorescent angiography, what you see is more than 10 disc areas of retinal capillary non-perfusion, as is seen in this picture, where the picture on the left shows extensive areas of capillary dropout, whereas on the right you can see not that many areas of CNP. And with the advent of ultra-wide field angiography, there is something called as an ischemic index, which is the ratio of capillary non-perfusion to the total visible area. If it is more than 45%, or if the total area of non-perfusion is more than 75 disc areas, this predisposes to neovascularization. Another potentially blinding complication of ischemic CRVO is the anterior segment neovascularization, which may lead to neovascular glaucoma, which is a blinding condition. So we also need to know the natural course of the retinal vein occlusion. Why is it important? We need to know the natural course of a disease to predict the treatment outcome. So in CRVO, if it is a non-ischemic type of CRVO, most of the cases have a spontaneous resolution, whereas in ischemic CRVO, there might be anterior or posterior segment neovascularization. And the potential of conversion of non-ischemic to ischemic is 12 to 30% over a period of 3 years. Whereas in a BRVO, most of the cases have a spontaneous resolution, but in BRVOs with extensive CNP areas, it is said that 40% of them would develop NVEs and 40% of those will have a vitreous hemorrhage. So now